Respected Chairperson, actually we will go to the Contrast PCI. Impact of the contrast-induced kidney damage is basically to increase the hospital stay, increase kidney injury and death. How to reduce the mortality? Definitely to reduce the prevention is the key to reduce the contrast volume. Ultra low contrast volume is actually the PCI to be done with the less than eGFR to be calculated. So the zero contrast PCI we do with the patients with the eGFR of less than 30, or if the eGFR is less than 45 with the patient's age is more than 75, LV ejection fraction less than 50, diabetic hypertensive patients. I'll be showing two cases where the 77-year-old patient with a 20% EF with a chance of creatinine. Patient has significant, this angiogram done early, just 7 days back, which have significant disease in the circumflex, ramus and LAD. So they have taken only 4 shots. This lesion, one is in the circumflex. You can see there is a lesion which with 3 marker wires you can keep. Which good look at the ramus, there is a significant disease. We can keep the marker wires in LAD and circumflex. And the lesion 3 is in the LAD, which is actually maybe 2 stents or 1 stent with marker wires can be kept in the LMCA in the diagonal and the septal arteries. So we took a 7 French EBU catheter with the filter FC wire directly going into the distal branch. You can see that the 4th projection, these right projections are taken earlier. We are keeping these as the markers. So we take the 2nd wire going directly into the distal pass, that is OM vessel, and we are keeping 1 more wire into the sinus nodule. So we have 3 marker wires. So then we do a 1.5 to 15 millimeter balloon dilatation, and then an IVUS done. After the IVUS, what we see is actually there is a 3 millimeter vessel proximally, and we can see a 2.6 vessel distally. So this balloon, because it is a 2.75 vessel, we dilate with a 2.5 millimeter balloon. Second, again, we take an IVUS. We can understand there is a 3 millimeter vessel, 2 millimeters away from the first branch and 8 millimeters away from the distal branch. So that is total is 2 plus 22 plus 8, that is 32. We have to take a 28 millimeter stent, 2.75 into 28 from the proximal to distal. So 3 millimeters proximally. So then we put the stent down. Post-stenting, we have to do the 3rd IVUS, actually the 3rd IVUS, where we understood that the repeat IVUS reveals an underexpander stent. So we have to do a balloon dilatation with 3 into 15 millimeter in the proximal part. Then we do 1 more IVUS to understand it is correct or not. The proximal part of the stent is still underexpanded. Take a 3.5 into 8 millimeter balloon, dilate it. Then we do an IVUS. We saw the IVUS showing the vessels are fully opened up from the proximal to distal, and there is no distal edge dissection as proximal edge dissection. So now we go to the ramus vessel, keeping the 1 wire into the LAD, 1 wire into the circumflex. Then the PCI done. When the wire is taken, it is not easily going. So we understood the proximal vessel is 2.75. We took a 2.5 into 15 millimeter balloon, and then we did an IVUS. So with the IVUS, we understood that the lesion is a 30 millimeter lesion. So 30 millimeter means you have to take a 33 millimeter minimum stent, keeping both the wires on either side, LAD and circumflex, and then keeping the wires aware, post dilatation with 3 into 12 millimeter balloon. Again, taken an IVUS. What IVUS shows that actually there is no distal edge dissection. Proximally, the wire is away from the both LAD and circosteum. And so far, you understand, we did not use a single drop of contrast. Then the wire gone into the LAD. We keep the wire, you can see the wire into the diagonal and wire into the septal artery. When the wire goes down, we understood this one. The distal vessel is 2.75 and the proximal is actually disease extending up to the ostium. So we did a balloon dilatation with a 3 into 12 millimeter balloon distally, and then keeping a wire 1 into this called metallic salute, 1 wire into the diagonal, 1 wire into the septal, and 1 wire distally. IVUS again. What IVUS actually revealed that ostial LAD is 4 millimeter vessel. Once it is a 4 millimeter vessel, we have to dilate and understand the ostial LAD to the bifurcation up to the diagonal is 14.9 millimeters. Distal LAD is actually 2.9 millimeters. So we took a stent from the ramus wire into the LAD proximal part up to the first diagonal, that is 15 millimeters, 4 into 15 stent. Subsequently, We have seen that there are 4 wires there with the stent inside. Then we took another stent, 3 into 28, because the distal vessel is 2.7 millimeters. So we took a 28 millimeter stent, then dilated. Then between the 2 stents, you have to post-dilate with a 3 into 12 millimeter balloon, remove the S1 wire, remove the diagonal wire. Then we post-dilate with a 3.5 into 8. And subsequently, we did a IVUS run totally. You can see the longitudinal mark down. It is totally opened up very well, and it is well opened up. So in this case, we did not use a single drop of contrast. 10 IVUS runs, 4 in the circumflex, 3 in the ramus, and 3 in the LED. So this is actually the final, and we just came out. Another patient is a 59-year-old patient with a creatinine only 1.3. But this patient had an angiogram done here. Distal LMCA bifurcation, Medina 111. The RCA was significant disease, and the patient was admitted with the ACS. They put a 2 deaths for ad hoc PCI with RCA. What really happened is actually the patient developed acute kidney injury by CIN. 1.3 creatinine went up to 2.1, and then patient was actually taken for a LMC intervention after 3 weeks for a DK crush technique. So we put the wire. You can see the catheter is taken. The wire is cannulated. We put the wire blindly, keeping the angiogram of the previous angiogram there. We put 1 wire into the OM and 1 wire into the LAD. And then we keep another wire into the septal artery, so create a metallic silhouette. Then the first IVUS run into the LAD. What actually we have seen, LMCA is 3.18 millimeter, ostial LAD is 3.27, diffuse fibrofatty plaque, and the lesion is extending. The proximal vessel reference of LMCA is 4.5, distal is 3 millimeter without disease in the distal part, and the reference actually at the septal mark is 3.68. So I can take a stent of 3.538 from LM ostium up to the septal artery, and distally I can take a 3 into 28. That measurement is done. Then we took a cutting balloon because of the fibrocalcification, 3 into 6 and 2.5 into 12 millimeter balloon. We have done an IVUS run to the circumflex to understand what is the length of the stent to be used. We identify the osteoproximal part of the circ is 4. Ostial OM is 2.62. We have to take a stent of 3 into 33. So my plan is to do a DK crush in this technique. So 2 into 9 cutting, 3 into 6 cutting balloon, and 2.2 into 9 cutting non-compliant balloon done. First stent is taken into the circumflex. That is actually 3 into 33. Then we did a crush with 3.5. Then we have done a side branch optimization. We crushed with a port crushed with a 4 into 8, all the steps without contrast. Then we side branch ostial stent opened with a 2 into 9 and 3.12. And first KBD done with 2 balloons, 3.512 and 3.58. These are all without any contrast. Now we did ostial flaring with keeping a wire in the sepal wiring done. 4.1 port with a 4.5 and 8. Then 3 into 28 stent middle LAD from the distal margin of the proximal LAD to the circumflex. And then we recrossed with the non-distal crossing done. Then 2 into 9, 3 into 12, serial high pressure dilatation done. Second KBD with 4 into 8 and 3.5 into 8. Then final part with a 4.5 into 8. We did an IVUS run from LM to LAD. We show 5.25 and no distal edge dissection. Proximal LAD is 7.69, 11.53 we got for LMCA. And we did, this is actually the clear stent taken. Then IVUS run from LM to circumflex, again proven it is 5.79. This is the final shot taken because of the insurance purpose, 2 ml of contrast, IVUS guided. We have done 109 cases so far. 92% of the cases are above stage 3. Syntax score is more than 23 in 61% of the cases. Diabetic population in 90%. And we do IVUS runs in 3.3 plus cases. We did complex zero contrast PCI. LMCA is 36 cases. Throat ablation in 12. 9 in CTO, including 1 retrograde CTO PCI zero contrast. 23 bifurcations. And we did absolute zero contrast. 135 patients and 38 vessels. We have to do some shot of contrast when there is a chest pain, ECG changes. Thank you.